Good morning. Welcome to everyone. This is a hearing entitled Meth Revisited, Review of State and Federal Efforts to Solve the Domestic Methamphetamine Production Resurgence. The committee will come to order. I want to thank all of our witnesses. I think we have two panels. I will recognize myself for purposes of making an opening statement, and then the distinguished gentleman from Illinois, Mr. Davis. Again, I want to welcome our witnesses and thank them for lending us their expertise and perspective. I want to extend a personal greeting to my longtime friend, Max Dorsey, wherever he is. Max and I work together. He is still a law enforcement officer, so he's still on the side of the Angels, but I was a prosecutor way back when, and Max, it's wonderful to see you. I know the witnesses are at the ready with statistics on methamphetamine and the problems permeating our country. When I think of methamphetamine, my mind doesn't go to statistics. It doesn't go to a debate between pharmaceutical companies and law enforcement. It goes to a couple named Ann and Ray Emery in the Drayton community in Spartanburg County in South Carolina. Ann and Ray Emery were a beautiful couple. They were active in their community, active in their churches, deeply in love with one another and full of life. They had a next-door neighbor named Andres Torres. Andres Torres was a troubled person with a long criminal history and an addiction to methamphetamine. He knocked on their door one afternoon and said he needed a ride to the grocery store to get some food, so Ray Emery, being the decent, kind human being that he was, stopped what he was doing and took Andres Torres to the store. And he even did one better than that. He bought the groceries for Andres Torres. That was the kind of person Ray Emery was. Kind, selfless, always ready to help a neighbor, even a neighbor as troubled as Andres Torres. About a week later, Andres Torres came back to the Emery home, but this time he didn't come in the afternoon. He came in the middle of the night under cover of darkness. He crept in through a side door. He walked into Ann and Ray Emery's bedroom and began to bludgeon Ray Emery with a hammer. 19 times he raised the hammer and struck the face or the head of another human being. Ray Emery's face was unrecognizable as a human face in the crime scene photos. He's laying there in a pool of blood on his bed with a skull fractured, and his left arm is reaching out towards his wife. His body is on the floor. She too had been bludgeoned with a hammer. Both of her eyeballs were absent. The bridge from her mouth was down into her neck, having been beaten there by a hammer, and she was raped post-mortem. So statistics are fine. They certainly have their place. If you want to see the carnage of methamphetamine, I invite you to come look at the crime scene photos with me from the state of South Carolina versus Andres Torres. Methamphetamine requires ephedrine and pseudoephedrine as precursors. These two drugs are commonly found in medicines that are also extremely beneficial to law-abiding citizens. It is interesting, at least for me, to note that I believe ephedrine and pseudoephedrine were both part of the federal schedule prior to 1976. And methamphetamine, at least to my knowledge, was non-existent prior to then. I don't know what the answer is. On the one hand, we know that those who seek to break existing laws, whether it be controlled substances laws or guidelines for the sale of ephedrine or pseudoephedrine, are adept at getting around whatever barriers we impose. On the other hand, it seems that 99% of our fellow citizens who follow the law and act lawfully are continually asked to change their behavior in an effort to combat those who cannot or will not conform to the law. So I look forward to hearing from our witnesses. Methamphetamine is an epidemic. You don't have to be a law enforcement officer or a prosecutor to know that. If the consequences of using and abusing this drug were just confined to the drug addicts themselves, it would be calamitous enough. But the consequences are far-reaching, even ending the lives of beautiful couples who happen to live next door. So with that, I would recognize the gentleman from Illinois, the ranking member, Mr. Davis.
Thank you very much, Mr. Chairman, and I thank you for holding today's hearing. Illicit drug use is one of the most challenging difficulties facing our society. It destroys families, individuals, careers, dreams, hopes, and tears at the very fabric of our basic communities. The damaging effects of meth that began in the western states have now infiltrated my state of Illinois and my hometown of Chicago. According to the United States Department of Justice, meth is the primary drug threat to central and southern Illinois, but is increasing in the Chicago area. The state recently ranked 4th in meth-related arrests. Estimates place the cost of the meth epidemic to Illinois alone at about $2 billion per year, when crime, loss of productivity, incarcerations, and the impact on families and children are taken into account. These are indeed stunning numbers. Our response in large has been to lock these folks up. The United States leads the world in the number of incarcerated people. There are some 2 million Americans in jail or prison. The United States incarcerates more people for drug offenses than any other country. With an estimated 6.8 million Americans struggling with some sort of drug dependence, our prison populations will burst at the seams if we continue with this course. I submit that drug treatment can and should be fully incorporated into the criminal justice system. Treatment services for addicts on the street and even those incarcerated must become more of a priority. Treatment must become a part of probation, parole, and drug court participation. By working together, substance abuse treatment providers and criminal justice system officials can optimize their resources. Mr. Chairman, we want individuals to become productive citizens and return to activities that benefit society. A Substance and Mental Health Services Administration study found that treatment decreases arrests for any crime by 64%. After only 1 year, use of welfare declined by 10.7%, while employment increased 18.7%. The numbers show it. Treatment can have a defining effect on a person, on a community, and on our country. Imagine if the dollars spent on incarceration could be put to other uses. I am certain that law enforcement officials here today encourage treatment as well. They see the same individuals withering away time and time again. These people could have been something or done something else with their lives. I applaud our law enforcement officials for coming. I respect what it is that you do. You represent the on-the-ground methamphetamine fight in our communities, and more often than not, put yourselves in harm's way. The intense battle against meth in rural America mirrors the urban fight against crack cocaine that dominated urban America in much of the 90s and on into today. I look forward to the testimony of our witnesses. Mr. Director, it's good to see you again, and I want to thank you for spending the day with us in Chicago exploring the different facilities and approaches that we've tried to make real and implement in our hometown. I thank you for the tremendous work that you do and look forward to your testimony and that of the other witnesses. Mr. Chairman, I yield back the balance of my time.
I thank the gentleman from Illinois. Members may have 7 days to submit opening statements and extraneous material. For the record, we now welcome our first panel. The Honorable Gil Kerlikowske is the Director of the Executive Office of the President's Office of National Drug Control Policy. Sir, welcome. Pursuant to committee rules, all witnesses must be sworn in before they testify, so I would respectfully ask you to rise and raise your right hand. Do you solemnly swear or affirm the testimony you're about to give will be the truth, the whole truth, and nothing but the truth? Let the record reflect the witness answered in the affirmative. Thank you. You may be seated. Witnesses typically have 5 minutes for opening statement. There should be a panel of lights. If there's not, I'll get you to rely on your internal clock. And with that, welcome.
Thank you very much. If my internal clock runs a little behind, if you'll let me know. Thank you, Chairman Gowdy. Ranking Member Davis and members of the subcommittee for the opportunity. Having spent 9 years as the Chief of Police in the Northwest, I'm very much aware of the significant health and public safety problems that result from methamphetamine use. Well, the national data indicate the number of current meth users in the United States has dropped significantly in the past several years. What these data don't capture, of course, is the considerable regional and local variations in methamphetamine production and use. Meth continues to be a drug of significant concern for both the public health and safety of many communities throughout this country. And frankly, given the regional patterns associated with meth, ONDCP was not as forward-thinking in recognizing the problem and proposing efforts to deal with it. Law enforcement intelligence reporting indicate the availability of methamphetamine in general is increasing in markets throughout this country. There is evidence of significant declines in price and significant increases in purity of the drug. Mexico remains the primary source of domestic meth supplies. From 2008 to 2011, the number of meth seizures along the border increased nearly 400%. Restrictions on precursor chemicals by the Mexican government had some initial success, but they do not appear to be as effective in the long run. Drug trafficking organizations have found ways to work around them. The increase in the supply of Mexican methamphetamine is paralleled by a growth in domestic meth production over the past several years. U.S. meth lab seizures more than doubled between 2007 and 2010, and these labs pose a major threat to public safety and the environment, as well as a significant burden on already busy law enforcement and first responders. And the growth in domestic production is attributable to increased numbers of small meth labs, and the shift in lab size is largely attributable to restrictions placed on precursor chemicals that made it difficult to obtain large quantities of the precursors that fueled the super labs. However, as in Mexico, producers here in this country found ways to circumvent the restrictions. Individual or smaller scale criminal groups have organized smurfing operations where individual purchasers acquire illegal quantities of the chemicals through multiple purchases from several retail locations. Well, the administration supports several important efforts to combat methamphetamine production and trafficking and to prevent and treat the drug. As directed by Congress, our National Youth Anti-Drug Media Campaign targets those areas of the country hardest hit by meth and delivers messages conveying the risks of meth use and the importance of treatment and the importance of recovery. And the administration is committed to working with the criminal justice system to reduce this problem. Our HIDAs, our high-intensity drug trafficking area programs, which are supported by ONDCP, are very much focused on this. The National Methamphetamine and Pharmaceuticals Initiative is a HIDA program working on the problem. Current federal restrictions on pseudoephedrine as a result of Congress's Combat Methamphetamine Enforcement Act, along with the majority of states with controls in place, were originally intended to cut down on production. However, the restrictions are showing some diminishing effectiveness. In an effort to address the resurging threat, some states implemented electronic sales monitoring systems for pseudoephedrine. However, there's growing evidence that these electronic efforts have been unable to contain a resurgence of the small-scale meth production. Domestic producers can and have been circumventing the system by simply employing large numbers of buyers with multiple fake IDs. Another prescriber control is to reduce pseudoephedrine availability through scheduling. And in 2006, Oregon made pseudoephedrine a Schedule III controlled substance, prescription only. Methamphetamine laboratories seizures declined dramatically from 190 to 11 from 2005 to 2011. Mississippi has had similar excellent responses, although their law has only been in place since July 1st, 2010. The administration is dedicated to working closely with the members of Congress on this problem. We have to focus on these strategies, and I look forward to answering any questions.
Thank you, Director. The Chair would now recognize Dr. Desjardins for his questions.
Good morning, and thank you for being here. Let's just kind of try to go through a bunch of questions because we have limited time. Does the ONDCP have an official position with respect to the best way to solve domestic meth production problems?
We have a position as far as it has to be holistic. We have to work on getting the message to these young people, particularly at about that 20 or 21 year age limit where oftentimes they begin to be involved with methamphetamine. We know that treatment works for those people that can get back into being productive citizens, and we know enforcement can work, not only working with countries to ban precursors, and I'll be traveling to China in September. Mexico has dismantled a number of laboratories, but they need additional assistance from the United States. And lastly, working with local and domestic law enforcement here in the United States, we've seen some real progress, particularly when I mentioned Mississippi and Oregon.
Okay. And yeah, I would like to talk more about those states as opposed to states that have instituted other point of sale restrictions or tracking systems. What in your experience is working best? Let's take Oregon, Mississippi, compare them to states like Tennessee that has tracking methods. What are you finding? What is your data showing?
Well, the data is showing that the number of lab incidents has been reduced in those two states in which the precursor chemical has been made a prescription only. And you have some experts that behind me that really know their particular state data very, very well. But I would tell you from my law enforcement hat, from many years, law enforcement has had a reduction in resources. And getting more leads and more information isn't quite as important as preventing the problem. And it seems like Oregon and Mississippi show great promise in preventing the problem.
No, I think initially when Oregon was probably first on board to do that, they did not have the same number of border states. And for example, Tennessee has 7. Now Mississippi, I think, did have more border states, and they showed similar results.
They've shown a decrease, and I believe the director of the Mississippi narcotics unit is on the next panel. I would tell you that what I've seen in Oregon, in particular in the Portland area, is that it's so easy to cross the bridge into my own state of Washington and purchase the precursors, and that's where oftentimes we see part of the problem. So I think that there's an important part.
Can the same reduction be shown in the states that have more sophisticated tracking systems or electronic logbooks? Are they showing a decrease, or is it steady or on the incline, or what's happening there?
So the decrease has been in the super labs, the large labs that produce a lot of methamphetamine. The increases in all of these labs, regardless of the state, is in the small use of a pop bottle, the kind of shake and bake method. And so we're seeing that. So we're not seeing that quantity, but we're seeing these numbers. And of course, even when these things are discarded on the highway or in playgrounds or anything else, they cause significant problems. They also drain public safety resources because of the hazardous materials responders that have to come out.
Let me ask this because I don't know the answer, but as a primary care physician for 20 years who has prescribed a lot of cold medicines, well, I know the answer to this. Does Sudafed have any curative factors?
I'm probably not at all qualified to give you that answer, but I know there are plenty of medications for runny noses on the market that don't contain pseudoephedrine.
Okay, what kind of kickback have they gotten in those two states from patients? Has it caused an increase in doctor visits and cost in terms of health care if they cannot get Sudafed over the counter and have to have a prescription?
I'm only familiar with Oregon, and one, it did not increase Medicaid costs. Number two, because it's a Schedule 3, that prescription can be called in. I mean, if you really need it,
Right.
you know, that can be sent telephonically to the pharmacy to be filled.
So if I have a patient that I know has severe allergies, runny nose, I don't have to make them come in for a visit. I can call in that prescription or give them a reasonable amount with refills for 6 months or more, so it doesn't necessarily mean they have to come to the doctor.
I believe so.
Okay. I don't have a timer in front of me, Mr. Chairman, so you'll have to, I see I'm on yellow. Quickly on the cleanup portion, you know, a lot of states, including Tennessee, ran out of funds just literally overnight, just flipped a switch, and they were out of funds. Is there anything on the horizon to help these states in terms of dealing with meth cleanup? You talk about the shake and bake bottles being thrown in the ditches, and if they don't have the money to clean them up, I'm not saying law enforcement looks the other way, but these are dangerous chemicals to deal with, and what can we look forward to in terms of help and support in the light of those funds running out?
There is the request in and for funding to replenish, and I think that and it probably is not enough given the number of small labs that are being seized, but there is some additional money there for that.
Okay, and I know my time has expired. We'll talk maybe in the next panel about some of the solutions that I know in Tennessee they went to multi-county storage containers and drastically reduced the cost of the meth cleanup by, gosh, it went from, say, $10,000 to $2,500 for a cleanup with these storage containers. So we'll talk more about that. And thank you, Mr. Chairman. I yield back.
Thank the gentleman from Tennessee. The chair will now recognize the gentleman from Illinois, Mr. Davis.
Thank you very much, Mr. Chairman. Mr. Director, we know that the use of meth dropped significantly during 2007 and 8 as states found ways to limit the supply and make it more difficult for individuals to acquire these key ingredients that were used to produce the concoction. But now we see that there is a rise and increase again. Does that mean that people are finding ways to get around these restrictions and in terms of purchasing the ingredients or storing them or having them? If so, how are they doing that?
You're absolutely right, Congressman. When Congress acted with the Combat Meth Act and put the pseudoephedrine behind the counter, requiring the logbook, that did have an impact. At the same time, the government of Mexico banned the precursor chemicals. Since then, two things have happened. One, the precursor chemicals are shipped in either under forged documents into the country of Mexico, or they're shipped into places like Guatemala and then come up into the laboratories of Mexico, and then the methamphetamine makes its way here. The second thing is that the smurfing that I talked about, in which large numbers of people with multiple fake identities can go from store to store and purchase the maximum amount of pseudoephedrine possible. And that is a way of getting around the Combat Meth Act and the logbook.
Are the sellers of these products required to maintain records and perhaps make those available to law enforcement officials to try and track what may be going on with the dealers?
They are required to maintain the logbooks, and they are required to provide that logbook to law enforcement. The issue that my colleagues always talk about, though, of course, is that they'd much rather see the crime or the incident prevented and the methamphetamine not made rather than devote law enforcement resources to try and track down information on what may often be a fake ID.
While I am a strong proponent of law enforcement techniques and approaches to try and really get a handle and keep the ingredients away or prevent individuals from having the meth to distribute. I guess I'm also a strong proponent of treatment because, well, I just grew up a very simple way where we were told that an ounce of prevention is worth much more than a pound of cure. And it would seem to me that if we could provide treatment, and we know that treatment, according to all the data that we've looked at, does in fact have a significant impact. How do we balance the law enforcement with the treatment in terms of resources and activities to make this the most comprehensive approach that we can?
Congressman, I couldn't agree with you more, and I'll be very surprised if any of my former law enforcement colleagues that'll be on the next panel would differ with you in the least. Law enforcement has been absolutely joined at the hip on both prevention and treatment programs, not only for methamphetamine but for other drugs. We have over 2,600 drug courts, and I know you're very familiar with them, having told me about the Chicago experience. 2,600 drug courts, many of whom deal with clients who, in fact, are addicted to methamphetamine. And I can tell you that the myth had always been that once someone was addicted to methamphetamine, they could never be cured. In my travels for this administration in 3 years, I have met literally hundreds of people who were severely addicted to meth, and included some pretty drastic problems, dental problems, health problems, etc., that are back taking care of their families, back paying taxes, back being productive citizens. So we need to make sure that the program that we have is comprehensive.
Thank you very much, Mr. Chairman. I yield.
I thank the gentleman from Illinois. The chair would now recognize the gentleman from Florida, Mr. Micah.
Mr. Chairman, first of all, thank you for conducting this hearing. Unfortunately, part of the problem of the situation I think we're in is Congress, 4 years, the other side of the aisle was in charge, and I don't recall a single hearing. I served as chair of the Criminal Justice Drug Policy Subcommittee from 98 to 2000, been on the committee all my time. And I'm trying to remember if there was even a single hearing relating to, well, there might have been some promotion of legalization of narcotics, but that might have been the only thing. So part of the problem of finding ourselves in this situation is that Congress wasn't doing its job. Having been involved in trying to tackle this issue in the past, this is sort of catch-up for me. And I have some questions. I think first you have to go after the source. If you're telling me Mexico is still the source and it continues to be the primary source, that's correct?
Correct.
Precursors. Help with Denny Hastert to develop Plan Colombia, which we had basically the same situation we have in Mexico now. Do we have a Plan Mexico? Does the administration have a plan to deal? I mean, almost all the narcotics and violence and precursors are coming out of Mexico, not to mention the wanton slaughter of tens of thousands of Mexican innocent citizens. Do we have a plan?
We do have a plan, and I believe that President Calderon could not have been more courageous during his 5.5 years.
Okay, there's a new president now, but yeah, he may have been courageous, but actually you just testified that this stuff is still coming in, and they're subverting the process.
Well, he took on banning those precursors, and they were pretty effective, but the drug traffickers have figured out two things.
But then you go to Plan B. Do we have a Plan B?
So the Plan B would be to continue the increases of seizures along the borders. Mexico has increased the number of seizures of their laboratories within the government, within the country, and they're working also to tighten their border, their southern border, where chemicals come into places like Guatemala and then make their way, the precursors, and then make their way
Well, the
to
other thing,
Mexico.
too, is seizures. I'm looking at this here, meth, DEA. You go back to 2004, 2005 in the Bush administration, 18,000 in 2004, and we're down to 10,000 seizures. Have we just become more tolerant? We don't. Are you working with DEA to increase the seizures?
Well, and the seizures are almost all done by Customs and Border Protection, as you well know, along the border. Part of the reduction could also be the fact that we have about half of the users in this country that we did.
Well, again, blaming it on the users is something, or treatment is another thing. Quite frankly, I believe when you get to treatment, you've lost the game. It's a first stop in the precursors to put the stuff together. If it's coming through Mexico, we need a plan, and plan B, whatever it is. Is the law we passed in 2004 working? You said it's being subverted. You know, we took some stuff off the shelf. We've got, but does Congress need to look back at this? And I mean, I'm a zero tolerance guy. I worked with Rudy Giuliani when he did that in New York, and the residual is still there. You go after people, and you have tough enforcement, and you curtail the bastards, pardon my French, and stop them, and that's what you've got to do in this. But when seizures are down, has the administration arranged a meeting with the new administration yet on the drug issue? Do you know?
President-elect Peña Nieto has not named, to my knowledge, any of the people that will be in his cabinet to head up the federal
Well, I think one of our
police.
priorities, and you should report back to this committee in Congress, is a meeting. This deserves the attention of the President of the United States. The slaughter across our borders now, the increase in use of methamphetamines, and then looks like we're sleeping at the switch in enforcement, and we don't have a plan really to deal with this. So the last thing, too, I helped set up the education program some years ago. I have no idea the status of it. I've gotten waylaid on transportation issues. But part of it is education. Tell me the status of that program.
The educational program, the National Anti-Drug Youth Media Campaign, was not funded by Congress last year.
Do we have, when we did this, the deal I cut with Clinton was that half the money was going to come from the private sector or from public broadcast. We own the airwaves, and they were supposed to provide some airwave education. That's part of their responsibility under the FCC law to provide. Do you have a program with them to provide some of that? We have on the air a meth anti-meth program.
We still, as required, spend 10% of that media money on meth. The most effective
But
meth
getting them, they have the resources and the capability and the airwaves and an obligation to use some of that for public education. Do you have a plan working with them now?
We work with a partnership at drugfree.org and others, but we also know some of the most effective methods are through social media.
Yeah, well, and we have a plan?
We do.
Okay, well, again, maybe you could provide me with some update on it. I think that's very important. And social media, too, is finding out in the campaign is very, very important, and a new way of getting to possible users and people affected by it. And if you can share with us, I think this administration, this president, you need to be in the face of Mexico. And if we need to go back and change the law, you give us the recommendations to update 2004, what other resources you need, and we'll work with you. Thank you, Mr. Chairman.
Thank the gentleman from Florida. The chair will now recognize himself for 5 minutes of questions. Let me start, Director, by thanking you for your previous service in law enforcement. And I was having a hard time getting my little noggin wrapped around in judiciary. It is not uncommon to hear some of our colleagues call for the legalization of what would now be Schedule I controlled substances. So to go from calling from the legalization, and I'm not saying you have, I've never heard you say it, but the disconnect between calling for the legalization of what are now Schedule I controlled substances to the quasi-criminalization of what are now over-the-counter drugs just seems like something of an inconsistency to me, but perhaps it's just me. Without waiving my Fifth Amendment right against incrimination, I don't think you can make moonshine without sugar, can you?
I'll take your word for this.
You can't write demand notes without paper and pen. You can't make cocaine base without baking soda. And you have to have water for moonshine and baking soda and crack cocaine, and there's never been any conversation about criminalizing any of the above. So at what point do we say, yes, this is an integral part of making something that is illicit or wrong, but the inconvenience of criminalizing baking soda or water or pen and paper is just a bridge too far for us? We're going to concentrate on the 1% that's breaking the law and not the 99% who do like they're supposed to do.
I think, I mean, your points are excellent. I guess when I talk to my colleagues around the country who are in law enforcement, they're all suffering from reduced budgets. They've had layoffs, they've had reductions in force, they've had, in some cities, increases in violence. And going after people with fake IDs who bought too much pseudoephedrine over the counter is not going to be on their highest list of priorities, and that's a fact.
Well, I'm not disagreeing with you, but I would wonder this: how many of these so-called Smurfs have been prosecuted for conspiracy? Because it just strikes me that our entire criminal justice or penal system is set up to get people's attention with incarceration, and one way to get the Smurfs' attention is to actually wrap them up in a Title 21 conspiracy count on the federal side. Do you know how many of these so-called Smurfs have actually been prosecuted for conspiracy?
I don't know.
I want you to put your old hat back on for a second and see if my logic is flawed. If you decrease the demand for, or decrease access to ephedrine and pseudoephedrine, you could probably fashion an argument, because you have seen addicts do things that are unspeakable in their quest for drugs. I have seen it. I just recalled a story about it. What's to say that we won't have an increase in home invasions for addicts seeking ephedrine and pseudoephedrine from families that have a prescription for it in their quest to get it? Have there been any studies showing whether or not the criminal element has gone to, because they're very creative, gone to other routes to get these precursors?
The only familiarity I have with the longer term on that is again Oregon, and in talking to law enforcement colleagues in that state, and I know you have a witness from the state of Oregon regarding break-ins to homes to get the precursor chemicals for meth, or stealing prescriptions for precursor chemicals for pseudoephedrine, has not been an issue of concern to them, but I would take their testimony with their experience over certainly my anecdotal information.
Is there the prospect or possibility that Mexico's production will increase if you accept that the demand for the product will remain the same without drug treatment? Then what's to say Mexico won't meet that request for increased production if it decreases domestically? What's to say we won't see an even greater influx of methamphetamine from Mexico?
I think as long as there's that demand here in this country, Mexico, those drug cartels will do their very best to try and meet some of that demand. That's why I think the prevention information about the dangers of methamphetamine, and there are some incredibly, as you know, graphic demonstrations of advertising that seem to have made a difference in keeping people off methamphetamine. Again, that'd be the far more important way to do this.
Well, my time is up. I will say this about drug treatment. We had a drug court in my home county, and the dirty little secret about drug court is it wasn't the prosecutors and it wasn't the police officers who were opposed to it. It was the criminal defense attorneys, because drug court is much more difficult to survive under or on than simple probation. So some of my colleagues who are opposed to mandatory sentences in all forms may have to reconsider when it comes to drug court. Because if given the choice between probation, where you just wave your hand once every 6 months, and drug court, most defense attorneys opt for probation. With that, you have a very difficult job, and we wish you great success, and we thank you for coming and testifying. And again, we thank you for your service to law enforcement as well as your service to our country.
Thank you, Chair.
We will stand at ease for a couple of minutes while the next panel comes forward.
You need something? Y'all need something? No. I think so. Yes, I believe so.
My guess is that we're going to.
Hi, Will. How are you? Nice to meet you, sir.
Just so you know, this is the light, but yeah, it also. Green when you have 4, when you have 5 minutes, and then when you get down to your last minute, it will turn yellow, and then it will turn red.
Thank you.
Just so you know.
Brooks for a minute. Just a minute.
Committee will come to order. It is our pleasure to recognize and welcome the second panel of witnesses. I will introduce you from your right to left, my left to right. I'll introduce you en banc and then recognize you each for your 5-minute opening statement. Mr. Ron Brooks is the director of the Northern California High Intensity Drug Trafficking Area and the president of the National Narcotics Officers Association's Coalition. Mr. Jason Grayler, and if I mispronounce anyone's name, correct me and forgive me, is a sergeant with the Franklin County, Missouri Narcotics Enforcement Unit and the president of the Missouri Narcotics Officers Association. Mr. Max Dorsey is a lieutenant with the South Carolina Law Enforcement Division in the great state of South Carolina. Mr. Rob Bobbitt is the district attorney for Lincoln County, Oregon, and the architect of Oregon's 2005 prescription-only law. Mr. Marshall Fisher is the executive director of the state of Mississippi's Mississippi Bureau of Narcotics and an architect of Mississippi's 2010 prescription-only law. Again, pursuant to committee rules, and I always wanted to have Max Dorsey under oath so I could ask him some questions, and now I will have my chance. So I would ask you if you would please stand and raise your right hand. Do you solemnly swear or affirm the testimony you're about to give will be the truth, the whole truth, and nothing but the truth? May the record reflect all the witnesses answered in the affirmative. Mr. Brooks, we will start with you and recognize you for your 5-minute opening statement.
Maybe you could hear me without it, because I think the... Okay. Mr. Chairman, Ranking Member Davis, members of the subcommittee, thank you very much for holding this important hearing and for inviting me to represent the 68,000 members of the National Narcotic Officers Association's coalition. I'm a 37-year law enforcement veteran, and I've worked methamphetamine investigations since 1980. I'm currently the director of the Northern California High Intensity Drug Trafficking Area. Every day, National Narcotic Officers Coalition members see firsthand the devastation, lost opportunities, violent crime, environmental destruction, and death that meth use brings to our cities and towns. It robs children of their parents, young people of their dreams, and our country of the bright minds and sound bodies that we must rely upon to remain strong as a nation. From the earliest days, it was clear that cutting off pseudoephedrine would virtually eliminate domestic meth manufacturing. When cooks could easily access pseudo at retail stores, we saw massive quantities purchased and converted to meth. As a result, the number of meth labs ballooned from 7,000 in 1999 to 18,000 in 2004. We were inundated. It was truly an epidemic, and it was clear that we needed to make meth more difficult, or needed to make it much more difficult for meth cookers to get their hands on pseudoephedrine. That's when the Congress focused on the issue and passed the Combat Meth Act. One of the primary purposes of the Combat Meth Act was to restrict access by meth cooks to pseudoephedrine by requiring behind-the-counter product storage and recording of purchases in a logbook. The facts tell a crystal clear story of what happens when we restrict pseudoephedrine. We went from 18,000 incidents in 2004 to 6,000 incidents in 2007, a drop of more than 65%, due in large part to the Combat Meth Act provisions to control pseudo. But the CMEA's restrictions eventually led to innovation by meth cooks who resorted to smurfing, the practice of purchasing small quantities of pseudoephedrine products at several retail locations to bring back to a central manufacturing location. We often see several people recruited to purchase a small number of packages and sell them to middlemen, who in turn sell the packages to illicit cooks. After the initial steep Combat Meth Act decline. Because of this smurfing technique, we saw a number of lab incidents increase again to 10,000 by 2011. Law enforcement situation is much more challenging today because of layoffs and budget cuts. We're not equipped to deal with the surge in lab incidents the way we did in the 1990s. The COPS Meth Hotspots program used to provide critical support to our efforts, but Congress has cut its funding by 70%. Unfortunately, the meth situation on the ground is alarming. Last year, 5,000 kilograms of meth were seized at the U.S.-Mexico border, a 400% increase compared to 2008. And the domestic meth lab production numbers are certainly growing across the country. There are really two clear lessons in history. The first is controlling pseudoephedrine is the best way to prevent meth labs. The second, half measures to control retail pseudoephedrine will lead meth cooks to innovate workarounds to these obstacles. The conclusion my members have drawn is that products containing pseudoephedrine should be accessible via prescription only on a nationwide basis. The fact is, making pseudo available only by prescription significantly reduces the number of meth labs in communities. My colleagues from Oregon and Mississippi will share clear evidence of the success of their prescription-only policies. We're talking about major declines in meth labs almost instantly from the passage of those laws. The policy works, and it should be embraced on a nationwide scale. Some will say that tracking retail purchases of pseudoephedrine is the solution to the smurfing problem. While tracking has a positive impact in some areas, the impact is really limited and is not proven to reduce labs. Again, the facts tell the story. Kentucky was the first state to implement a tracking system. Every year since the implementation, the number of lab incidents in Kentucky has gone up. Tracking is reactive and very labor intensive. Relatively few agencies today have the resources to effectively track pseudoephedrine and make an impact, a true impact on their meth problem. We're encouraged by the recent development of technology that has been shown to prevent pseudoephedrine from being extracted from pills, which means that illicit cooks could not use it to make meth. This would enable products containing pseudoephedrine to be sold in front of the counter. Consumer convenience and access to legitimate medicine would be enhanced and meth lab incidents would decline. Those developments really should be encouraged and explored. Mr. Chairman, we have a clear evidence of a policy that can save lives and protect communities. We really ought to act now before we lose control of this situation. On behalf of the dedicated men and women who respond to meth lab incidents every single day, the NNOAC strongly encourages Congress to study the Oregon and Mississippi examples and to pass a federal law that makes pseudoephedrine products prescription only. And I want to thank you for your time. I'm happy to answer questions.
Thank you, Mr. Brooks. Mr. Greller. Mr. Grellner.
Mr. Chairman, Ranking Member Davis, members of the subcommittee, thank you for providing me the opportunity to testify before you today. I'm Detective Sergeant Jason Grellner. I'm a task force commander of a unit in Franklin County, Missouri, just outside of St. Louis. I'm also the president of the Missouri Narcotics Officers Association, and I'm here representing the 350 members who struggle daily to fight methamphetamine laboratories. Missouri has consistently led the nation for more than a decade in clandestine methamphetamine laboratories, reporting over 27,000 found meth lab incidents since 1994. My task force has federally indicted 50 people for smurfing and manufacturing meth in just the first 6 months of this year, and we usually annually indict 50 people. During my 21-year career in law enforcement, I have led investigations of over 1,600 meth labs in Franklin County. My unit investigates a lab incident on average once every 3 days. I have often seen throughout my career the rippling effects that clandestine methamphetamine laboratories have on the elderly, addicts' families, innocent children, and the public at large. Approximately 50 children a year in Franklin County are removed from meth lab homes and placed into state custody. Over the past 15 years, I've earned the name Boogeyman, given the number of times I have taken children away from their family due to methamphetamine labs. The business of methamphetamine lab production is both painful and costly. At nearby Mercy Hospital burn unit in St. Louis, the director is quoted as saying that on any given day, at least 15 to 25% of their burn unit beds are occupied by uninsured meth lab burn victims at a cost of over $6,000 per day. In June of 2002, well into my 26th consecutive hour of work, I made the mistake by opening a container that contained anhydrous ammonia, an ingredient in the manufacture of methamphetamine. This poisonous gas caused immediate burning to my eyes, nose, mouth, throat, and lungs, and later a blistering of my mouth and throat. I was eventually diagnosed with lung disease, where it was found that I lost 25% of my lung capacity. In the last 6 months, 5 of my 6 investigators have been hospitalized for cancer, kidney transplant, an unknown tumor growing in their chest because of methamphetamine laboratories that they have investigated. As I look back over a lengthy career, I know that 80% or more of all crime revolves around drug and alcohol addiction. For this reason, the Franklin County Narcotics Enforcement Unit is built on the principles of prevention, enforcement, and rehabilitation. Our offices are home to 3 prevention specialists and 7 narcotics investigators. We are members of local drug court team. At our facility, we host counseling service and pay for housing of participants in the drug court program. We have our own 501c3 foundation, helping to build strong community coalition to prevent addiction before it starts. We understand that law enforcement, substance abuse prevention, and rehabilitation must work together in order to have a long-lasting effect on narcotics crimes and addiction. I know the growth of meth labs is a direct result of the decision made by the United States Food and Drug Administration in 1976, when the agency faced a decision as to whether or not pseudoephedrine hydrochloride should be an over-the-counter drug. By allowing pseudoephedrine to become OTC, I know the face of narcotics law enforcement in this country changed. Now what we're faced with more recently is a new black market of pseudoephedrine that has transformed this product from a commodity to currency. We commonly now see heroin addicts and those addicted to prescription pain relievers using boxes of cold tablets containing pseudoephedrine in trade for their narcotics of choice. A box of pseudoephedrine in Southern Illinois and St. Louis now sells for $100 a box. Criminals now go to the pharmacy not to receive beneficial medication, but to exchange currency. In 2009, I began a campaign asking local cities and counties to enact ordinances requiring a prescription for pseudoephedrine. Washington, Missouri, enacted its ordinance on July of 2009. In the 90 days prior to the ordinance, 5 pharmacies in Washington sold 4,346 boxes of cold tablets. In the 90 days following the enactment of this ordinance, those same pharmacies saw a 94% drop in sales and only sold 268 boxes. Inspecting sales records at pharmacies surrounding Washington during the same time period saw no rise in sales after the implementation of the ordinance. This city also experienced an 85% decrease in meth-related calls for service by the police. Tracking databases which track the sale of PSC in real time do nothing to halt the spread of methamphetamine labs. Missouri in 2011 alone tracked 1.76 million sales. Missouri sells 1 box of pseudoephedrine every 17 seconds. The state experienced a 6.8% increase in meth labs between 2010 and 2011. In the southeast portion of the state, where nearly 70 cities now require a prescription for pseudoephedrine, we saw a 52% drop in methamphetamine labs, and I see I'm out of time.
Thank you, Mr. Grellner. Agent Dorsey.
Chairman Gowdy, Ranking Member Davis, committee members. My name is Max Dorsey, and I serve as a lieutenant with the South Carolina Law Enforcement Division, commonly known as SLED. I'm currently a supervisory special agent in the narcotics unit, and I'm also my agency's clandestine laboratory coordinator, responsible for directing matters related to the enforcement of South Carolina's efforts to stop manufacturing of illegal narcotics. Thank you for the opportunity for me to participate in this committee today. South Carolina is experiencing a meth lab epidemic that is severely impacting law enforcement's resources and jeopardizing the welfare of our citizens. Despite both state and federal efforts to prevent domestic methamphetamine production, meth labs in South Carolina continue to rise at an alarming rate. As you know, meth labs are very dangerous. Entering a meth lab site is one of the most dangerous acts a law enforcement officer can do. Yet as labs become more numerous in our state, we find more innocent people harmfully exposed. For example, in May of this year, a horrific fire occurred in the Pine Harbor apartment complex in Goose Creek, South Carolina, killing 3 people. The victims of this tragedy were 4-year-old Samuel Garb, 19-year-old Morgan Abernathy, and 69-year-old retired Air Force captain and Vietnam veteran Joseph Rath. These people did nothing wrong. They were victims of circumstance. Their circumstance was that they were in their apartment in close proximity to a meth lab. Although the manufacturing of meth cannot be exclusively proven to be the cause of the fire, it appears, based upon information present at the scene, that it most certainly may have contributed to the spread of the fire. During this manufacturing process, something went wrong and a fire ensued, causing the destruction of 16 units in the complex and the death of 3 innocent victims. Over the past decade, several states and Congress have passed legislation in an attempt to combat the meth lab epidemic. Most of this legislation has sought to control access to meth's main ingredient, ephedrine and pseudoephedrine, which are also main ingredients in cold medicines. In 2005, Congress passed the Combat Methamphetamine Epidemic Act, which sought to limit daily purchases of ephedrine and pseudoephedrine-based products, thus restricting the amount of this necessary meth precursor chemical in the marketplace being diverted for the domestic manufacturing of methamphetamine. The pharmaceutical industry supports tracking precursor chemicals and brought forward a potential solution known as the NPLEX system. The intent of NPLEX was to better electronically track ephedrine and pseudoephedrine purchases through a central interlinking database. Despite the good intentions of NPLEX, it has not stopped domestic meth manufacturing in South Carolina. NPLEX is not limiting illicit purchases. In fact, in our first year of utilizing NPLEX, South Carolina actually saw an increase in discovered labs. Any legislation that seeks to merely lower the purchase limit or track purchases does not effectively combat domestic meth production. It is too easy for criminals to subvert the CMEA and NPLEX through the practice of smurfing. These criminals simply steal identities or use fake IDs to make their purchases. Neither CMEA nor NPLEX has done anything to reduce the number of meth labs in South Carolina. In response to the growing meth crisis, Oregon and Mississippi passed new laws to prevent ephedrine and pseudoephedrine from entering the criminal marketplace by requiring a prescription to purchase ephedrine and pseudoephedrine-based products. The results of Oregon's and Mississippi's legislation have proven to be the most effective approach to combating domestic meth production within those states. If we're serious about combating domestic meth production, Congress must pass legislation returning ephedrine and pseudoephedrine to prescription only. We have seen the absolute success of this approach in Oregon and Mississippi, as meth manufacturing has plummeted in those states. President Ronald Reagan once said, "To sit back hoping that someday, some way, someone will make things right is to go on feeding the crocodile, hoping he will eat you last. But eat you he will." Committee members, the crocodile is alive and well and is preying not just on our criminal justice system, but our environment, our health care system, our social welfare system, and our economy. The committee has an opportunity to put the crocodile back in its cage and stop the domestic meth lab production in this country by rescheduling ephedrine and pseudoephedrine. Thank you for your time, and I'll be happy to answer any questions you may have of me.
Thank you, Agent Dorsey. Mr. Bovett.
Chairman Gowdy, Ranking Member Davis, and members of the committee, my name is Rob Bovett. I'm the District Attorney for Lincoln County, Oregon, but I guess more importantly today, I'm here as legal counsel for the Oregon Narcotics Enforcement Association. As such, I help craft much of Oregon's drug policy and laws that addresses not just enforcement, but treatment and prevention. I'm here today to talk specifically about pseudoephedrine control and effective pseudo control. I'm not here to talk about reducing the meth epidemic. I'm here to talk about reducing the domestic manufacturing of meth. The truth is, most meth comes from Mexico, and it has for a long, long time. We're talking about the impacts, the devastating impacts of meth labs. In 1976, we let a genie out of the bottle. We allowed pseudoephedrine to be sold over the counter. It was a mistake. It was a huge mistake. Ever since then, we've been putting Band-Aids on the situation for the last 35 years, both in state legislatures and in Congress. It hasn't worked. The Band-Aids have been temporary patches on what is effectively a gaping wound. And here we are again. Here we are again with the smurfing epidemic that is pervasive across our nation. It does manifest itself differently in different parts of the nation. In the Midwest and the South, All of this smurfing of pseudoephedrine fuels thousands, tens of thousands of these one-pot user labs. In the West Coast, it's different. All of this smurfing fuels super labs in Central California. California produces more meth in domestic meth labs than the next 4 states combined. So we have a slightly different problem in the West Coast than in the Midwest and the East and the South. But the problem all stems from the same core problem: smurfing, smurfing, smurfing of pseudoephedrine. In 2006, actually in 2005, we passed legislation in Oregon to return pseudoephedrine to a prescription drug and end the smurfing problem. It went into effect in 2006, and we eliminated smurfing. It can't be done in Oregon. It can't be done in Mississippi. And I should say, there was a parade of horribles ramped up, and it's still ramped up today, about all the things that would happen. There would be public outcry, demonstrations, there would be home invasions, there would be robberies of pharmacies, there would be doctors' offices swamped with people. The truth is, it's been over 6 years in Oregon, and none of that has happened. None of it. The truth is that we effectively eliminated the problem of smurfing in Oregon. We no longer contribute to the domestic meth lab problem, and there's no one clamoring to undo what we did over 6 years ago. It is a real solution to end the problem of smurfing, to correct a mistake that should never have been made 35 years ago. But only Congress can actually fix this nationwide, because yes, Oregon has a handful of meth labs remaining each year, but it's all traced back to pseudoephedrine smurfed, as the director mentioned, in Washington or Idaho or California, in one case, Nevada. So we truly need a nationwide solution to this nationwide created problem from 1976. The truth is also that most consumers have long ago switched to alternative decongestants. When you enacted the Combat Meth Epidemic Act in 2006, in the spring of 2006, and it went in effect September of 2006, virtually by that time, most consumers had long switched to stuff that was easy to access. Hundreds of products line the shelves. We're not talking about those products. We're talking about 15 remaining pseudoephedrine products that are all behind the counter. And so we see massive smurfing going on in places other than Oregon and Mississippi. I will tell you, and I've provided you references in my written testimony, that our medical community overwhelmingly not only supports but strongly supports what we did in 2005 that went into effect in 2006, including the Oregon Medical Association, our pharmacists, and our College of Emergency Physicians, because it works. It not only works and it's effective, it didn't flood their offices with demands for these products that most consumers just simply don't seek. It is a real solution. I appreciate the time. We need to put this genie back in the bottle, and only Congress can do that. I look forward to your questions, and thank you very much for the time.
Thank you, Mr. Bovett. Mr. Fisher.
Mr. Chairman, Ranking Member Davis, committee members, on behalf of the state of Mississippi, we appreciate you having, I appreciate being here today. I'm a 35-year veteran of law enforcement. I've been the director of the Mississippi Bureau of Narcotics for the past 7 years. Prior to that, I was a special agent with the Drug Enforcement Administration. My first undercover narcotics purchase as a street agent was methamphetamine. So that was some time ago when my hair wasn't gray. In 2005, Mississippi passed several new laws designed to curb methamphetamine production. One of them was limiting the amount to 3.5 grams on a daily basis and up to 9 grams in a 30-day period. The other was to require a log to be signed by individuals purchasing the pseudoephedrine, wherein they would have to provide some form of identification. We saw an initial decline in labs about 18 months into those laws being passed. Then they began to steadily climb. In 2009, we recorded 713 meth labs in the state, 129 children being taken away as what we call drug-endangered children, being taken out of the meth labs, many of whom had been physically and sexually abused. We had over 3,000 arrests from my agency alone that year, and 1/3 of them were for narcotics for the first time for methamphetamine. For the first time in the history of the state of Mississippi, they exceeded a combined total of crack and powder cocaine, those arrests. So we began to figure out what we were going to do as a solution. We looked at electronic tracking. You've already heard from some of the other witnesses here today about Kentucky It was considered the gold standard state. I did a tour in Kentucky with the Drug Enforcement Administration. I had colleagues that were still there, still on the job, who told me it simply wasn't working. Their meth labs were increasing. I talked to a judge in the state of Mississippi who routinely removes children of drug-addicted parents from the custody of those parents, and he told me in the entire time he's been on the bench, he's never removed one child from a meth-addicted parent where the parents come back to court to even bother to petition the court to get the child back. He also told me numerous anecdotal stories of children, preschoolers, who had STDs passed to them sometimes by their own parents, meth-addicted parents. We came to the only viable solution that we thought would do this after some intensive study, and that was to make pseudoephedrine prescription only. We enacted the law in 2010. We've had 2 years to study it, to see the results of what has happened and would happen in Mississippi. We had the same parade of horribles, including the cost of Medicaid going up, and I actually have a document with me from the Director of Medicaid in Mississippi, for the record if you would like it later, showing that there's been absolutely no effect on over-the-counters. There was a requirement for prescription for over-the-counters already anyway from the Medicaid department. We had 546 total meth incidents in the first 2 quarters of 2010. In the same 2 quarters of this year, we've had 162. More importantly, in the first 2 quarters of 2010, from January through June, we had 252 actual methamphetamine labs. In the first 2 quarters this year, we've had 17. 17. That's a 93% reduction, and the only thing we've done different is schedule pseudoephedrine. The numbers speak for themselves. Our supporters of the prescription legislation wanted to adequately support law enforcement, protect our children, and preserve public safety. We like to say in Mississippi there's no middle ground on meth labs. You're either for meth labs or you're against them. This is a self-created, self-inflicted epidemic that we can do something about here in the United States of America. We cannot control what the people in the Republic of Mexico do, in Afghanistan and some of the other places, Colombia and Peru. We can control this, and it frees people up, investigators up, to work on organizations who are actually bringing in methamphetamine, such as the Mexican cartels. Prescription-only legislation is not just the right choice, it is the only legitimate choice for this country. We would have money freed up for the treatment of addicts, be astounding numbers. Most of the people with the one-pot methods that we're seeing are addicts. 99% of them, 1 to 3 yield grams, one pot method. Most of these people are addicts. Putting the addict in prison is like painting your house when it's on fire. It is not a solution. Thank you for your time.
Thank you, Mr. Fisher. Chair would now recognize the gentleman from Tennessee, Dr. Desjardins.
Thank you, Mr. Chairman, and thank you all for your testimony and for being here today. Had a conversation this morning with Tommy Farmer, our great director of Tennessee's Meth Task Force, and he mentioned several of you by name, so I assume you're friends, and we're very fortunate to have him. Let me start, Mr. Bovett, what kind of kickback have you gotten from the patient population in your state since this law has been enacted?
Congressman, the short answer and one-word answer is none.
Okay, so who is in greatest opposition to Sudafed becoming a controlled substance?
Congressman, the pharmaceutical industry, and primarily, not directly the pharmaceutical industry, but primarily through their surrogates, various foundations and associations that virtually represent them.
Mr. Fisher, you concur with that?
Yes, sir.
Okay. You know, clearly the Inplex system that we have in Tennessee, I think this panel is saying that it just simply is not effective. It's not working. Back when it was not in place, an individual go out and buy 100 boxes. Now with Smurfing, 100 individuals go out and buy 1 box, and there just simply hasn't been any significant decrease in the number of labs. Is that correct? Yeah. Okay. Mr. Fisher, or actually, Mr. Bovet, I was just looking at some of the numbers. The surrounding states around Oregon, some people say that it's just going to increase. It looks like to me the numbers in Washington, Idaho, California have dropped since your law has been passed. Is that just statistical noise, or is there a reason for that?
Congressman, there is a reason for that. We saw a definite drop in meth labs across the nation, including the Northwest and the West Coast, following the Combat Meth Epidemic Act. But the resurgence in the West Coast is different than it is in your part of the nation. The resurgence in the West Coast is a resurgence towards super labs in California. So there is massive amounts of smurfing going on in cities like Las Vegas and Reno and Phoenix and Seattle every day. But primarily that fuels the super labs in California, as I mentioned. And so Nevada, for example, held a hearing on this very issue last year and is developing momentum to do this. They have just a handful of meth labs each year, and why would they do that? Because smurfing, as mentioned by the other speakers, smurfing has become an enormous problem in those states with the black market, with even heroin addicts being able to convert $5 to $50 or $100. So it's manifested itself slightly different in the last few years. I would also caution you about some of the numbers that the industry banters around. They tend to use a federal database that is not exactly accurate. For example, Washington State doesn't accurately and fully report their meth lab incidents to the federal government, so there's issues relating to that as well.
Okay, let me play devil's advocate just for a second. I'd like to see what your opinions are. Would you all agree that prescription narcotic abuse is on the rise and becoming a huge problem? Okay, so here we have a situation where we have controlled substances and it's increasing. I'm sure if those drugs were over the counter, the problem would be astronomically higher. What would you say to critics that say those systems aren't working? If we make Sudafed a controlled substance, why do we think that'll work when we already have tools in place? And we'll just kind of, Mr. Grellner.
The main reason we have such a prescription drug abuse problem here in the United States is because of opiate pain relievers, and pain is subjective. A doctor such as yourself has to rely on his patient to tell him the amount of pain he's in and the quality of that pain. This is an objective problem. If you have inflammation in your sinus and ear canals, that can be objectively looked at by the doctor, and the proper medication can be administered by the doctor. They're two different subjects. Prescription drug abuse is a horrible problem, but it's opioid pain relievers at over 5 million abuses a year that is the problem with prescription drug abuse, not pseudoephedrine.
If I could just briefly add from Oregon's actual over 6 years of experience, we do have, as I mentioned, a handful of meth labs incidents each year. We trace the pseudoephedrine to its source, and in over 6 years of actual experience, we've not had a single meth lab incident where the pseudoephedrine was prescribed pseudoephedrine. For all the reasons that Mr. Grellner has outlined, plus a few more, we just don't see that as a problem, and it hasn't occurred.
Mr. Grellner, you mentioned burn units. I just wanted to mention our largest burn unit in Tennessee, Vanderbilt University. Right now, fully 1/3 of the burn patients there are meth-related burns, and I think our cost is about $10,000 a day.
You spent Vanderbilt University burn unit in 2009 spent $9 million of their own money on uninsured meth lab burn victims.
Well, unfortunately, that light is red over there. I'd love to visit with you more, but thank you, and I yield back.
Thank the gentleman from Tennessee. The chair would now recognize the gentleman from Illinois, Mr. Davis.
Thank you very much, Mr. Chairman. Let me thank you gentlemen for your testimony. As a matter of fact, I was sitting here thinking that I've heard lots of testimony during the many years that I have been a member of legislative bodies, and yours is perhaps the most compelling that I have heard in terms of a very clear direction for what can become a real impact on not totally eradicating, but certainly putting a serious damper on a problem. If the information that we've gathered from the Oregon and Mississippi experiences, then it's difficult for me to think of any reason that we couldn't duplicate those experiences throughout the country. Let me ask Mr. Brooks, as the national leader, have you heard much reason why we couldn't duplicate across the country the experiences of Mississippi and Oregon?
Well, I can tell you the primary reason has been the strong push by industry to oppose it. We tried to pass a very similar law in California, SB 486, where we received a deep opposition, a very strong lobbying effort by industry to prevent that. They were successful. They derailed our bill. Other states and other local government entities, counties and cities that have tried to schedule pseudoephedrine have had the same experience. So we really think that the answer here is a national law. We think that the evidence, as you say, sir, is very clear. This works. It's not a hypothesis. It's a proven fact. But we've got to overcome the push by industry. This is a multi-billion-dollar industry. The over-the-counter pseudoephedrine industry is there's a lot at stake. And I think we have to collectively as a nation have the courage to step up and do what's right for our kids and our communities.
Well, even, I was trying to rationalize why industry, and of course you could see some concern, but then if their products are so good, physicians are going to be prescribing them anyway, to a real degree, I would assume. Dr. Destiny, would that not be the...
Well, if the gentleman would yield, as far as Sudafed being so good, phenylephrine is also good. It's being dosed in lower milligrams than it could be or that it is in other countries. Sudafed also brings a lot of worries for our diabetic hypertension patients and clearly children, so I think there are viable alternatives.
Yeah, but even so, it probably would still be receiving a great deal of consideration on the part of people who needed to make use of it. And I guess for me, the good that it would do certainly outweighs whatever disadvantage it might cause. I mean, I, for one, would be prepared to support, at this moment, national legislation to if we can reduce the number of labs that are being created, if we can prevent the kind of accidents that are occurring and taking place, and then the ultimate impact on the lives of the individuals who become addicted, then it seems to me that, it's as clear as day that we need to move in the direction that you've suggested. And no matter what the opposition might be, you'd certainly have one vote in the House of Representatives in favor. I thank you for your testimony, and Mr. Chairman, I yield back.
I thank the gentleman from Illinois. The chair will now recognize himself for 5 minutes of questions. I want to preface it by saying I'm going to play the devil's advocate just because somebody's going to ask the questions, and we got to be prepared for it. And I will start with Mr. District Attorney. You've had wonderful success in Oregon. The gentleman from Mississippi has outlined wonderful success. You had no blowback from physicians, which is unusual. None from patients. Why have the 48 other states not followed suit?
I think this was in part, Mr. Chairman, alluded to earlier, the industry. The industry is very successful in lobbying and preventing this legislation from moving forward.
What argument do they use that is most compelling with state legislators in the face of the overwhelming evidence you and others outlined to the contrary?
Mr. Chairman, I think Kentucky is the perfect example where they've had the electronic tracking system in place for the longest period of time. and it has simply failed to deliver the promise to reduce meth labs or smurfing. It's an investigative tool, and that's all it is. So the argument they make is one of patient access. The arguments they make are the parade of horribles that have been mentioned. All these bad things are going to happen. And in Kentucky, they actually set a new record, a state record, for the amount spent on lobbying. And that doesn't even include their public campaign in terms of advertising. Massive amounts of money they spent to kill the bill in Kentucky this year. We simply can't compete with that.
Special Agent Dorsey, I'm going to lay aside Oxycontin, Lortab, the pain treatments, because I understand the point that Mr. Grellner and the district attorney made. But we've also prosecuted phentermine and fenfluramine, which are diet pills. There were entire cottage industries, and still are, around bariatric medicine for weight loss. What's to say that we won't have those same mills crop up when it comes to runny noses and sniffling, and instead of this panel of experts, we'll have DEA diversion experts saying we need more help going after doctors who are essentially prescription mills?
As you well know, drug addicts are quite creative, and there are opportunities and ways that they will go out there and they will come up with techniques that will surprise you and I. But here is an opportunity to, it's an inconvenience. It will be an inconvenience. But what I would point to you is, in my state alone, since NPLEX has been going on since January 1st of 2011, from the numbers we've been able to show, only approximately 15% of South Carolinians are buying this stuff, which surprised me.
Have you seen prosecutors who are willing to roll up Smurfs in Title 21 conspiracies, or whatever the state equivalent is in South Carolina?
I can't speak to the federal side. I'm aware of a state grand jury case in South Carolina that did that. The problem is that hole that you create from sending those people to prison fills up so fast. And so it's just not a practical solution, prosecution of these people, because again, for every person you put in prison, you're gonna have 10 more to replace them.
I think they call it the Hydra effect. All right, I'm going to do what I love to do with law enforcement officers, which is talk philosophy. From a philosophical standpoint, the public is tired of having its behavior changed because a certain percentage of people just cannot comply with the law. I doubt y'all have worked very many or prosecuted very many arson cases that did not involve an accelerant, but there's been no discussion of scheduling gasoline or kerosene. You've never worked a bank robbery case where there was a demand note and anyone advocated that we do away with papers and pens, or a stabbing that didn't involve a sharp edge. And I understand that these are somewhat absurd examples, but nonetheless, there is a frustration within the public that it's always us that's inconvenienced because of the criminal element. While the criminal element, to your point, Agent Dorsey, is just going to find another way around it. So how do you strike the balance between, and you've convinced me, I was convinced before I got here, it's an epidemic. All the things that y'all have said about methamphetamine times 10 are true. But how do you strike the balance with the law-abiding public versus the criminal element when it comes to placing barriers? And whoever has read Kant most recently can take a stab at it.
Can I take a stab at it for you?
Yes, sir.
We're not inconveniencing a large amount of society that's being inconvenienced already by the meth labs. A RAND study in 2007 said United States taxpayers in 2005 on the low end spent $23.4 billion on the meth lab problem in the United States. We're all being impacted by it already. When I look at the sales of pseudoephedrine in Oregon, a state of 3.9 million Americans, they're selling about 9,700 boxes of pseudoephedrine a month by prescription. When you come to the great state of Missouri and look at the tracking system, a state of 6 million people, that would mean we should sell about 15,000 boxes a month. We're selling between 120 and 165,000 boxes a month. 90% of these sales go directly diverted to methamphetamine laboratories. They're not being used. They are a commodity. When we have individuals standing on parking lots of pharmacies paying people $20 to go inside and buy pseudoephedrine to bring back outside so they can sell it to a meth lab for $100, it is not a commodity anymore, sir. It is a currency.
All right, last question because my time is up, and I know none of you are old enough to have been around in 1976 when the decision was made to take it from prescription to OTC. Probably. Probably. By the looks, none of you were around. What was the argument made in 1976 of why we need to take this from prescription to OTC?
If I could answer that,
sure.
Mr. Chairman. I've done extensive study on the history of this, wrote a law review article about it, and spent a lot of time on this. This actually began in 1962 with a mandate from Congress to the FDA to study a broad spectrum of drugs to decide which drugs should be allowed to be sold over the counter as a modernization effort. It took them basically 14 years to get the monograph established for OTC cold and allergy medicines. And so they went through an analysis of what was safe and effective for use. And the primary problem with that analysis is it looked at the drug itself for its intended purpose. It didn't look at the drug for its illicit purpose. So while the DEA and some in the DEA said, hey, we don't think you ought to do this, they were looking just at the confines of the drug itself. Is it safe and effective? Now, I actually have arguments, I would love to talk with the good doctor at some point, about why this drug should never have been moved from the schedule to OTC to begin with based on its pharmacology. But that's a separate argument. But I think that's the answer to your question.
Recognize the gentleman from Missouri, Mr. Clay.
Thank you, Chairman Gowdy. And, you know, the problem of meth in my state of Missouri is very troubling. In fact, Jefferson County, which is close to my district, has had by far the largest number of meth labs in the state. The meth problem is so pervasive that some people call it Metherson County. Detective Sergeant Grellner, in Missouri, meth is a formidable foe, and I appreciate your efforts to eradicate this menace from our state. And as president of the Missouri Narcotics Officers and as a narcotics unit commander, I know you have had specialized training. Can you detail for us training for law enforcement, the equipment necessary to uncover the clandestine meth labs and interact with children on the scene and handle those combustible products?
Yes, sir. Thank you. First off, it takes 4 officers off of to do a methamphetamine laboratory and specialized training. That takes 48 hours of specialized training that's given to us by the DEA, so it takes them out of my office for a week to 2 weeks in Washington, D.C. at the DEA Training Academy. Once they come back to me, then we have to buy suits that cost up to $500 per suit to wear on the scenes with the new flame retardant properties that they have. Special air purifying respirators are necessary, as well as self-contained breathing apparatus and specialized air monitoring units. Sitting on my parking lot right now is a $250,000 vehicle that we take to methamphetamine laboratory sites to fight meth labs. That money could have been better spent in the Department of Corrections working on the rehabilitation of individuals that are addicted to different drugs. On top of that, when those 4 officers go out to the scene, they're photographed by the press and the media, and they can no longer work undercover on problems such as prescription drug abuse and heroin and cocaine. They spend several hours on the scene. Then they must transfer hats and become a hazardous waste company and clean up the hazardous waste that's left behind. They have to transport that to specialized buildings throughout the state of Missouri where they must store the hazardous waste, categorize the hazardous waste, and make it for pickup by the EPA. Then they have to write the reports and testify in court. Oklahoma did a study in their state that said that one meth lab with conviction cost their state $350,000 per conviction.
that really strains law enforcement budgets throughout the country, I'm sure. Over 45 cities and towns in Missouri require consumers to have a doctor's prescription to buy any form of pseudoephedrine. This applies to about 400 pharmacies and businesses. How effective have the local ordinance been in halting the sale of ephedrine or pseudoephedrine within the local community?
First, I'm happy to report that that number has gone from 45 communities to 71. Almost 600 pharmacies now require a prescription in the state of Missouri. The state of Missouri also has a tracking system fully implemented and been online since January 1 of 2011. The state of Missouri realized a 6.8% increase in meth labs in 2011. However, the area in southeast Missouri, bordering Kentucky and Tennessee, two other high states for meth labs, where most of these cities are located, saw a 52% drop in meth labs in their area in 1 year's time. And sales of pseudoephedrine are down from 165,000 boxes to 120,000 boxes in June of this year. And when I've gone for the last 3 years to over 200 city and county council meetings, the question that I am asked by every committee: have you told this to the state government and have you told this to the federal government? Why haven't they taken care of the problem? Why do we at the city and county level have to take care of a problem that's a national problem?
Can Mr. Brooks or anyone else on the panel, can you discuss the increase of meth use in urban and suburban areas?
Well, I think, certainly we are seeing, and you've heard testimony on dramatic increases of meth use and meth labs. I think the problem we're dealing with here is really that domestic meth lab production problem, because we're going to continue to get meth brought in from other source countries. So clearly the issue here is not as much about use, although it certainly is. It's more about reducing that dangerous, toxic problem in our communities. Children in meth labs, toxic waste dumping into our waterways and into our communities, dangers to first responders, police officers, and other first responders that you heard Sergeant Grellner describe. I personally have held the hand of 2 friends as they died from cancer that were police officers that had worked in meth labs, and I've had countless other friends that are suffering from that. The impact on our community budgets. And I'll tell you the other thing, sir, that the thing that is really tough right now, these are labor-intensive investigations. In California, we have had such dramatic cuts in budgets. We have now at least 70% reduction in law enforcement resources to work drug crimes, 70% fewer cops to work these drug crimes. And so when we start to see some reductions, I think part of why we see reductions is because we don't have anybody out there looking. We don't have anybody out there able to work these crimes. And California is not the only state in the union that is cash-strapped. Clearly, if we're going to have an impact on environmental impact, on the drug-endangered children problem, on the danger to cops and firefighters, we're going to need to control pseudoephedrine.
Thank you.
Thank the gentleman from Missouri. With your indulgence, because we do have such a wonderful panel of witnesses, and this is such an important issue, if your time allows, we were going to perhaps go to what we call a second round or a lightning round. I will do my best to reduce the time to 3 minutes that we have from 5. Are y'all amenable to that? Do your schedules allow? With that, I would recognize the doctor from Tennessee, Dr. Desjardins.
Thank you, Mr. Chairman. And I think as my good friend Chairman Gowdy said, we need to take advantage of the witnesses we have before us. Let's assume that what we've been talking about today happens, and we do pass a law that allows that this become a prescription or a controlled substance. That is going to turn the attention back to the physicians, the prescribers, and the law enforcement. We were at a meth summit in Crossville, Tennessee, and had over 100 law enforcement agents, and I found it interesting that I quickly removed my congressional hat and put on my physician hat, because I felt there was a great disconnect between law enforcement and physicians, and we were talking more about narcotic drug abuse. But do you find that there is maybe a poor communication between law enforcement and physicians, and if so, what can we do to improve that? Yes.
If you don't mind, I'll take that one. In our effort to schedule pseudoephedrine in Mississippi, I approached the Mississippi State Medical Association, the Board of Pharmacy, the Nursing Board, Board of Health. The Medical Association got on board with us, and now with the prescription drug abuse issue, we have the Prescription Drug Monitoring Program in Mississippi, and we're having a difficult time getting physicians to buy in to use the PDMP, if you will. Most of the states have it. Some of them are in various forms. But that one of the things that was useful for with us with respect to scheduling pseudoephedrine is we've got a population of roughly 3 million, give or take a few there. There's somewhere north of 500, between 500,000 and 550,000 prescriptions written on a monthly basis. 2.5% to 3% at the highest is what we've seen with Sudafed prescriptions, and that's at the height of the cold and flu season. But what I've encouraged other law enforcement counterparts to do across the country is establish those relationships with the medical community.
And I would just say we have an opportunity right now in Congress. We have a large number of physicians. We have a physician caucus with 20 members, over 600 years experience, and I can speak, I think, for 95+% of physicians. There's bad apples in every profession, and you all know who they are, and through pain management clinics there's been ways to skirt the rules and look legal, even though we all know pill mills are out there. But I would encourage meetings with our caucus and ways to open those channels of communication, because I can guarantee you physicians don't want to have to treat meth patients. They don't want to see these burn labs. And I think because of regulations, whether it's HIPAA or other compliance issues, there's some paranoia among physicians about what their rights are in terms of reporting patients and using these databases. So that was the one thing we established, that I think we're on this, well, I know we're on the same team, the vast majority of us, and we need to find a better way to deal with this.
If I could add just briefly, Congressman, I would echo all of your sentiments and Marshall Fisher's as well. What happened in 2005 in Oregon is our physician community, our dental community, our nurses, our pharmacists were all part of the solution, and actually they were some of the champions for it. What it's done is has paid off in dividends subsequent to that, because we now have we didn't before have a working relationship for dialogue about things like prescription drug abuse, which we never had before. So actually we kind of came together to deal with meth labs, and we came away from that with friends and partnerships.
Okay. I see my time has once again expired. Thank you, Mr. Chairman.
It goes so quickly, doesn't it?
It does.
Thank you. The gentleman from Tennessee would now recognize the gentleman from Illinois, Mr. Davis.
Thank you very much, Mr. Chairman. I guess my one question would be, how do we increase the collaboration between all of the components as we've had this fight against proliferation of drug use, both prescription drugs? Yes, there are people who abuse them and abuse them greatly, but then it's the illegal drugs that we see that have taken such a drastic toll on our society as a whole. I come from an environment where our county jail can't keep the people who are picked up. Actually, we have more than 10,000 people. I mean, we have the largest county jail system and the largest unified court system in the country. And we are spending enormous amounts of money. How do we increase this collaboration between all components of the community to reduce our reliance upon drugs?
Congressman, very briefly, I can only speak from the Oregon experience. I saw that dramatic change occur in 2004 in Oregon because everybody was operating in their own silos. And what happened was our governor had the foresight and wisdom to put us all in the same room. So he called together prevention and treatment and enforcement and, most importantly, the recovery community. And he said, come up with real solutions. And once we started working with each other and talking to each other, the amount we could accomplish together was phenomenally greater than the individual silos.
Well,
Speaking for my task force, we're the first task force I know of in the country that in its own building incorporates prevention, enforcement, and rehabilitation. We understand that to have that impact, you have to have all three working together. We hold NA and AA meetings at our building. We provide housing for the drug court participants. We provide training for the drug court participants. And we also allow training for prevention programs in the high schools and junior highs. You have to bring those three together like a three-legged stool.
well, I thank you all very much.
Would the gentleman yield, just not to downplay the impact of the illegal drugs, but I know someone on the panel wanted to say it, the rate of overdose from drugs is higher with controlled substances, prescription drugs, than it is illegal drugs. Is that the case?
Yes.
So just to be aware of how severe that problem is.
Well, I appreciate your understanding of the entire system, and especially the whole question of recovery. I do something once a year called a recovery walk, and I usually have 300-400 recovering individuals who might walk 2 or 3 miles or whatever we decide. And I think the understanding that comprehensively is the only approach that really will work to reduce the dependence upon external substances. So I appreciate your testimony.
Thank the gentleman from Illinois. I'm going to continue with my trend of anticipating the defense argument. There's a bill pending in Congress right now, Mr. District Attorney, dealing with copper theft, which is also an epidemic. And at first blush, you want to sign on to it because it's a horrible problem in South Carolina. I assume it is in other places too. People disabling air conditionings, construction sites. And then you stop and think, well, if somebody goes to a neighborhood in Greenville or Spartanburg, South Carolina, and cuts the copper from an air conditioning unit and then takes it to a scrap metal dealer, where's the interstate nexus? You saw the Supreme Court in Lopez, despite the fact that we don't want guns on schools, say that the Gun-Free School Zone Act was unconstitutional because it wasn't sufficient interstate nexus. You saw with Morrison, we've all lived with domestic violence, which is a horrific epidemic nationwide and certainly in South Carolina. And in Morrison, the Supreme Court struck down Congress's efforts to fix that as saying that it was not sufficiently nexused with interstate commerce. I understand the schedules are already federal. If Congress passed something and gave the states an opt-out, how many states would opt out? How many states are you having trouble not just persuading that there's a problem, but how many states would affirmatively opt out if there were a federal solution?
Mr. Chair, I'm not exactly sure. I believe this is a federal matter. It long has been a federal matter. The schedules are controlled federally. So I think there, frankly, shouldn't be an opt-out, because the minute you have an opt-out, you create a hole. You create a hole that basically bleeds out to the neighboring states, because the pseudoephedrine in my state that's used to make the meth labs happen is from Washington, Idaho, and California. I don't want Washington opting out and electing to essentially subject me to what should be their meth labs. It doesn't make sense as a national policy to do an opt-out. I do understand your concern with the case law and the trends we've been moving forward. I think, again, looking at Oregon, back to your scrap metal example, we struggled for years mightily with that issue until they finally got tired of it, and they came to me and I crafted up some legislation that so far has been working. But it wasn't something that I could have got done in 2000. We had to go through about 10 years of trauma before we got to people willing to actually implement a real solution. And we've gone through 35 years of trauma when it comes to pseudoephedrine. It's past time to actually implement a real solution.
All right, last question. Our culture prefers prison. Other cultures prefer other means of corrective measure. Have you ever made an effort to publicize the stores that are selling a disproportionate amount of ephedrine or pseudoephedrine, or name the pharmaceutical companies that are uncooperative?
Yes, sir. I pour over the files that come in from the database every month, and I post the top 30 stores in our state that are selling pseudoephedrine, which happen to be in the top 10 counties for meth labs. Right now, One corporation, one large chain store, owns 9 of the highest selling stores in the state out of the top 10. They own 17 out of the top 20, and they continue to sell. They sell cold packs that are used to manufacture meth in 1-pop bottles. They're an 8-pack box now. An 8-pack box of instant cold packs. And now you can buy one for $9.99 and get another one at 50% off. Who needs 16 instant cold packs? Someone who manufactures methamphetamine.
So if you were testifying at trial and I asked you in front of the jury whether or not you had exhausted every other means of combating this epidemic, shy of scheduling ephedrine and pseudoephedrine, your answer would be?
Yes, sir. I have worked on this problem and worked on legislation since 1999 and have been pushed back by industry every year with a solution that does not work. And I'm baffled why legislators, when listening to officers on the street, don't believe us.
Chair will now recognize the gentleman from Missouri, Mr. Clay.
Thank you, Mr. Chairman. And Detective Grellner, along those same lines of questioning, what has been the response of the large retailers when you have brought the issue to them and had strong evidence that they were supplying this chain of meth manufacturing?
I liken it to this. If a constituent called in and said that there was a man on the corner in your area selling 90% of the heroin in your area, you would expect law enforcement to go to that corner, immediately stop that man from doing that, incarcerate him, rehabilitate him, and take care of the problem. Our street corners in Missouri, especially in the St. Louis metropolitan area, are lined with big box pharmacy stores that are selling 90% of their pseudoephedrine diverted to methamphetamine laboratories, hiding behind FDA rulings, their attorneys, and their lobbying efforts.
Let me ask Mr. Bovet. I have a letter here from my local chapter of the NAACP. Let me share with you what they just highlights. It's our firm belief that efforts to combat meth production should be focused on legislative solutions that target criminals, not law-abiding citizens. In the past, some lawmakers have advocated for a mandate that would force all consumers to obtain a doctor's prescription before buying common cold and allergy medicines containing pseudoephedrine, because some criminals misuse those medicines to make meth. We strongly oppose that approach. It would raise costs for thousands of St. Louis residents. Not only would a prescription requirement lead to additional co-pays and fuel costs, it would also result in lost wages for workers who are forced to take time off from work to visit a doctor. What would be your response to the St. Louis chapter of the NAACP?
Congressman, I would say that I'm a little bit surprised at that approach. I think they need to maybe do a little more research, find out what the real implications of doing this are. That sounds more like the pharmaceutical industry's parade of horribles. I would also encourage them to check with the California chapter of the NAACP, which actually testified literally right next to me in favor of Senate Bill 484 in California, which Mr. Brooks mentioned, saying that prevention is the correct approach, not arrest and incarceration. And what we have before you here today is a pure prevention solution to the meth lab problem, because frankly, law enforcement does not want to track down, arrest, and incarcerate more Smurfers and meth cooks. It's an endless supply. We want to actually prevent the problem. So I would encourage your chapter of the NAACP to contact us, maybe do a little further research. I think they'll realize that what we're proposing is a prevention solution and just the opposite of the criminalization approach that they're proposing.
Thank you for that response.
Thank the gentleman from Missouri again on behalf of all of us. We cannot thank you enough for your time, for loaning us your expertise. I think you've convinced everyone, if they didn't already know, that it's an epidemic, and we value your perspective, or at least I do, very much. So with that, our committee would stand adjourned.
Thanks for your question.
follow-up questions, just give me a shot.
That was a good one, Dan. Very good. It was kind of bipartisan.
That's exactly. You missed Mr. Micah going